They basically just intubated the mouth. I can't go on any further. I can't do it. Get down and give me 50. But don't literally drop that Thor hammer of morphine on them. Come on, guys, like, what are you doing? Would not recommend training at this residency at all. It was done horribly. Literally, he just shoved it in. Welcome to your next lawsuit. Even if that burr hole is done perfect, you will save nobody. It's on the wrong side of the head. Congrats, you are drilling a hole on the wrong side of that patient. Welcome back. If you're new to my channel, this is ER Medical Drama Critiques, where I analyze and take a deep dive into various TV medical dramas. This is my second YouTube channel, with Physicians for Wishes, my first channel, granting wishes to cancer patients, nursing home patients, and doing various community give back videos. So feel free to check that out. I'm a board certified emergency medicine physician, and I practice full time. And I can promise you, I'm not gonna hold back. I'm gonna take a deep dive into every TV medical drama, and we're gonna critique it for being realistic and accurate. Next up on my list was a very popular request, and that is the pilot episode of Code Black. I had numerous requests. Dr. Taylor, can you review Code Black? Dr. Taylor, I want you to analyze it as an ER doc. Please do Code Black. You got it. Now, before I review and do a live reaction, I wanted to do my research behind Code Black to really set up the dynamic going forward, to really establish that baseline, especially for people that have not watched Code Black before. So Code Black first premiered in 2015, and the storyline is that it takes place in an overcrowded and understaffed ER in Los Angeles, California. Now, it's advertised as taking place in the busiest and most notorious ER in the nation. The TV show was adapted from a documentary in 2013 that followed the lives of young physicians at a Los Angeles County hospital. Now, obviously, this TV medical drama takes place at Angels Memorial Hospital in LA. It's not a real hospital, right? It's not the same, but it's created for this TV series. It's advertised that the average hospital in the United States is in Code Black 5 times a year, and this hospital is in Code Black 300 times a year. So in doing research for this, I came across an ER nurse that worked in the hospital the TV show is based on. Her name was Irma Hinkle. So she stated, in quotes, "Code Black is a concept to describe an emergency department that is overcrowded and lacking resources." So while Code Black isn't an actual medical term, the resources at the former LA County Hospital ER were sparse in one of the busiest ERs in the country. A new renovated building opened in 2008. She goes on to say, "When I worked there, the average wait time was 12 hours for patients who arrived at the front door." That's a long time. So patients were treated in the hallways most times, or in small rooms separated only by curtains. Often there were multiple patients coming in with traumatic injuries caused by gang violence, car accidents, and other traumatic events. So far I'm pretty excited to review this. I mean, what could go wrong, right? We have a documentary, then we had some people that decided to create a TV medical drama on that. The only issue becomes, did they hire the right ER doctor team, or the right, physician team to review the script, various cases for medical accuracy? How loosely is the medicine portrayed to make it entertaining, but then you're also risking the accuracy? So we're gonna find out, because again, I'm not gonna let back. As a full-time practicing ER doc, we're gonna critique this down to the small detail. All right, so a few key players that I did look up that I wanna know at least a little bit about before we actually watch this. So we have Dr. Leanne Rorish. She's actually the residency program director. We have an individual by the name of Mama, who is a senior nurse, so pretty excited about that. Definitely sounds like kind of like the boss, kind of charge nurse of the ER. We have Dr. Guthrie. He's another one of the attending ER physicians. We have Dr. Neil Hudson. He's an attending ER physician and former British Indian surgeon, so that's going to be an interesting dynamic if he's actually both. Without further ado, we're going to be doing Code Black pilot episode. Please be realistic. Please be medically accurate. Let's go. Already super excited, at least how they're portraying this. We get some of the the words on the screen. Average ERs in Code Black 5 times a year, so already pretty interesting.
Residents, Dr. Rorish will be here shortly. For now, you got me. I'm Jesse Salander. For the next 3 years, I'm your mama. I'm the senior ER nurse, and I can promise you there's nothing that goes on in this house your mama don't know about.
So far, we're off to a decent start. These 4 individuals are starting their residency, and we learned this is day 1. We also learned this is a 3-year program. So if you've watched my previous critiques, you're aware that as an intern, you're gonna rotate through various different specialties. So to clarify a few things, is this July 1st? We don't know yet. Just because we have 4 interns starting does not mean it's July 1st. They could have been on other rotations during previous months, and this is actually their first month in the ER, because not every emergency medicine resident is gonna rotate in the ER July 1st. My first month in emergency medicine was not until around the 3rd month or so, but overall, we're off to a decent start, so I do have some high hopes for this.
Try hiding something, your mama will find out. You think you're smarter than your mama because you got an MD? Well, you are not. Your mama knows when you're lying, crying, or dying.
Charge nurses know everything.
It's not only my job to teach you right from wrong, but to make sure you don't leave here in 3 years thinking you can do no wrong. Guys, can we clean this up, please?
You resident or attending?
First year resident like you. My name's Krista.
Mario, where'd you intern?
UCLA. Can't beat the tuition, right?
Well, no, NYU. We're paying off loans till your age.
Paying off loans for a long time.
Thousands of newly minted doctors like yourself.
So I really try to analyze everything for being both accurate and realistic. I want it 100% accurate, 100% realistic. And he asked her if she is a resident or attending. For starters, emergency medicine residents would have all that, they would know all that information, orientation. They would know who is who is not an attending, who's a resident, you would know all this already. Now, I'm gonna let that slide because maybe it's this massive residency. Maybe this intern just wasn't paying attention, so not sure, but I'm gonna let that slide for now.
Apply every year to learn emergency medicine in the Civic Cathedral, which you are about to enter. This is why you're here. The most favored strip of hospital real estate in the nation, where emergency medicine was born, where the Secret Service preserved the trauma bed for the President of the United States when he
This is all very realistic. This is what it looks like.
Angels Memorial. These stalls around the perimeter, which we call the sides, are for the patients who put off dying for a few minutes. And then this here, this is for the ones who are trying to die on you right this second. This, ladies and gentlemen, is center stage.
Center stage. So this is the name they basically give for the high acuity side of the ER. I will say various ERs actually give a different name for this. So they may say Red Hall, Trauma Bay, TRU, for example, so trauma resuscitation unit, trauma room, etc. So I love center stage, pretty cool. I'm not gonna lie, it's kind of fun to say, hey, bring them to center stage. So I wouldn't mind using that myself. It's actually pretty cool.
People come here for one reason and one reason only, to get one last miracle. Now,
because it's
your
a
mama's
beautiful
house
day to
is
save
a
lives.
#1 rule. And in order that you properly obey this #1 rule, ask me all the questions you think are stupid. Why? Because you're gonna be too afraid to ask daddy. So better to ask me than to violate the #1 rule, which is that you are not, under any circumstances, allowed to kill a guest in my house.
Yeah, you tell him, Mama.
If he's mama, who's daddy?
Somebody's at the door.
Homeboy drop off. Let's move. That's Daddy. Grab some gloves. Follow me.
What the hell's a homeboy drop-off?
Gangbangers leave their wounded on the sidewalk.
This is getting exciting.
Homeboy drop off. It sounds racist. They gave that name, not us.
Homeboy drop-off, she states. Now, I've talked about this in previous critiques when reviewing The Pit. 100% realistic, this does happen. It's a term used when individuals are dropped off at the EMS bay, literally in the front, not in the front like where you come in the ER, they're literally in the EMS bay. The car rolls up, someone is stabbed or shot, they're rolled out of the car, sometimes thrown out of the car, and sometimes the car just drives off. Sometimes it stays, but most of the time it's gonna drive off. Now, I trained in Detroit, Michigan, that's where I did my residency, and we would have something like this happen weekly. So to hear the exact same thing, the same term used here, it actually brings back some memories for sure.
Oh my God.
What the hell? Keep it together. Come on.
Got a heavy bleeder up front. Check the back. Back's empty. Gunshot wound to the neck. Obliterated carotid. He's lost half his volume here. Jesse, we gotta get him out of here.
Let's get the gurney underneath him, please. Go.
All right, you get over there on the other side and push with both legs.
Let's go, let's go, let's go.
2, 3, go. One more time, let's go.
1, 2, 3, go.
All right, you, right up top. I can do it. Get up there. Okay, all right, careful, careful. Put your finger down where my finger is, right? Feel that little thing wiggling around like a worm trying to get away? Okay, that's a carotid artery. Your finger is now the only thing keeping that man alive. Okay.
All right, gunshot wound to the neck, obliterated carotid, lost half his blood volume. She did not waste that much time getting him out. Love that. It's rather quick. Get him on the gurney. Love this so far. All I can say is please do not screw this up. I will say obliterated carotid. Remember, this is a gunshot wound to the neck, the carotid. When you hear the word obliterated, all right, that's not simply just a hole in the carotid. That carotid is likely just shredded. And all that, all the pressure in the world may not be able to make the bleeding stop. So I hope they do not screw this up here. It started off so well. Let's continue.
Watch the crush. Life is measured here in split seconds. Hesitate and people die. I'm gonna need some suction.
Literally split decisions on the spot.
Call the blood bank. Tell them I need 6 to 8 units and notify the OR.
Copy that. That's the level 1.
So initially the patient apparently had lost a pulse, right? The carotid was pumping, and the ER doc they called Daddy, the residency program director, stated to the intern it's the only thing keeping him alive was holding direct pressure. And now we lost a pulse and he's doing CPR. So not sure exactly when he lost it, likely. If it's a gunshot wound, it was a hemorrhagic shock, lost so much blood, and then they go into cardiac arrest. Likely that happened on the way into the ER. That happens. When the patient was in the ER, we hear MTP. So if you caught that, that means massive transfusion protocol that's being activated. Basically, it's going to be a lot of blood product being delivered, so 100% appropriate there.
Got a gunshot wound, male, 1 hole. I don't know if there's more.
FPP, now.
RSI atomic, 20 milligrams. Sucks 140, please. Push it out by Mark. Meds are ready. And push it now, please.
All right, so I definitely have to stop here to give props for the CPR. I love this. I won't say this too often. The pit, anyone from the pit watching this, take some lessons from Code Black with CPR only so far. I'm not saying the whole medical drama overall, just with the CPR. Like, holy cow, this looks great. They're over the patient, the arms are extended. One scene, like the arm's a little bit bent, but this looks real. Like, what artificial body did they get for this? And why doesn't the pit have this body? Like, why can't we use this one? Now, you may say, what resident's on the bed, right? Why is this resident on the bed doing CPR? I did this a handful of times in residency. When you're transporting a patient, and they're in arrest, you're trying to get them to a room, you want to be able to perform the best CPR. And you can imagine if the bed's going by, you're on the side of the bed, you're trying to do CPR, it's not going to happen. You hop up on the bed and you do CPR. That's realistic. That's totally fine.
Okay, now's a good time to get down. Come on.
Copy that. Do you want me to get the labs for transfusion type and cross-match?
No, but you can take on CPR.
But the blood loss is critical.
Look at his pulse, doctor. This man's heart needs assistance. Stop compressing until you can intubate.
Oh man, so the second intern CPR just sucked. First part was totally fine. The second part was not good. Now the difference with the first intern, on the bed doing CPR, that was awesome. He got down and now the bed is too high up for the second one to get above the patient. So the bed does need lowered a little bit here. Again, I was hopeful on CPR, but I'm gonna give them partial credit for at least making it look real to start with. So if the pit can take a lesson from the first intern doing CPR, do that one. Don't take a lesson from the second intern doing CPR. Let's just skip that part.
You got it?
Yeah.
Who can tell me why this patient cannot be transfused with type and cross-match blood? Anyone? Blood's here. It takes an hour. He doesn't have an hour. He needs ONEB, which is here now. Thank you, Jesse.
6 units, that's a lot of blood.
By the time he gets sewn up, he'll have lost that and more. Hang on, she's right.
Yeah.
It's going to take a vascular surgeon an hour to replace that vessel. He doesn't have an hour. He doesn't have 10 minutes. And all that blood's going to end up on the floor underneath the dead man. It's Friday night, Mama. We're going to need that blood.
Yes, we will.
You're not going to transfuse him? You're just going to kill him?
What?
What's going on?
I need a VAS cap. There's Elsa Claving and all the cold saline I can get.
Yeah, good.
Who can tell me what I'm doing? I need somebody to say
Something dumb.
Anyone? I'm replacing all of the patient's blood with ice cold saline. Why am I doing that?
He shouldn't be. He's already decompensated.
I need assistance, doctor.
No, that's something dumb.
Black with no sugar.
That's a man on that table, Leanne.
Are you ready to speak yet?
The theory of cold infusion is that can create a temporary suspension of animation through hypothermia, buying the patient, in theory, the hour it'll take a surgeon to repair the artery.
Bingo. So you were right. We are going to kill him. We're going to kill him to save him. All right. Let it go.
I'm in.
Let it go. Yep,
So a few things with this. A VAS cath is a temporary dialysis catheter. It's basically this central line, this large catheter. We're going to give a large volume of fluid through this. So sometimes in a trauma, if we don't have a trauma cordis or we run out of a trauma cordis, we can put in a dialysis catheter. We can administer blood product and fluid this way. Now, here she's asking for all the cold saline she can get, right? This is honestly ridiculous. Replacing all the patient's blood with ice cold saline, basically this is like a cold suspension and inducing hypothermia. Now, inducing hypothermia, cold saline, this is a great thing, just not in this situation. This is 100% not realistic. The patient is not just in an arrest related to a STEMI, a heart attack, or something like that. This is hemorrhagic shock leading to cardiac arrest. You gotta be kidding me. So I can tell you this, she would not be able to infuse cold saline fast enough in her attempt to cause hypothermia to preserve brain function. This is 100% not realistic. In terms of what she's doing, the patient literally has zero blood volume left, and the saline infusion is not going to change that. The average size male has 5 to 6 liters of blood. Even if you infuse cold saline to try to replace all this, the amount of time for infusion and for that hypothermia and the amount of time the patient remains in cardiac arrest, this is a 100% mortality. This is futile. I had so much hope for this, especially with how the first resident was doing CPR. Now I lost it. Now they try to set it up. It's the only way to potentially save that patient. I can't go on any further. I can't do it. Dan, I think I'm done. This is ridiculous.
What if you just tell them what they should do instead?
I potentially could do that. But basically, for starters, we know they applied pressure on the way in. That won't work for this kind of injury. Now, if you have a small hole in the carotid, sure, hold pressure. Stab wound, small GSW, so gunshot wound, hold pressure. In this case, they stated the carotid was destroyed. This is shredded. Putting a finger in the carotid is not enough to get the bleeding to stop. Hence, it's why it's dripping all over the floor, right? You see it literally dripping on the floor. So some MacGyver things that can be done, again, temporary only. The patient still needs blood. They still need the OR, but it can be you insert a Foley balloon through that hole, aim up a little bit further in the neck, just above where it's shredded, and inflate that balloon. Again, this is an emergent situation only. There's certain things that you do in emergent situations only to stop the bleeding that you wouldn't do otherwise. So I had so much hope for this, and now I don't even want to play this. I really don't. We're at like 5 or 6 minutes in right now, and I don't want to continue. Oh, let's go.
Fall off your board?
The rail was sketchy. I think it's broken. I can feel bones crunching around in there.
You high right now?
Why, you want some?
Cute. Come on.
You're only as good as your wait time out here. You want to love your patients? Fine, thank you. But you better love the ones out here just as much because they may need you more.
Angus Layton.
Eli Pineda. Wait, you're Mike Layton's brother? He talked about you.
You know him?
I was just a med student when he was resident, but everyone knew Mike. He's a superstar.
He crapped his bed in summer camp. He was 12, but it counts.
We separate them into 3 categories of acuity, ESI 1, 2, and 3. ESI 1 is critical, bullet wound, heart attack. The 2 is rough, but it's not death's door, pneumonia, blood clot. ESI 3, the flu, migraine, minor laceration.
ESI 1, 2, 3. That stands for Emergency Severity Index. Every ER is going to have a way to categorize a patient's symptoms when they present to the ER. Like 1 is exactly what she's saying. A 1 is like immediate. These are typically patients that need immediate intervention. They come as a trauma, it's an arrest. They immediately need BiPAP, right? They're impending respiratory arrest, for example. An ESI of 2, these patients have a high risk of needing quick intervention. And then, of course, an ESI 3 is urgent. These patients, they're stable, but they still need labs and imaging and things like that.
Are we going to be seeing our own patients today? For now, you'll be taking light cases and assisting the attendings, unless that board says code black, in which case half of LA is in this room, and then all bets are off.
Doctors.
75-year-old male. Started speaking gibberish at dinner.
Bay number 4.
He's gonna need TPA.
Dr. Layton.
TPA, I think he needs TPA.
I didn't ask, but I'm sure Dr. Guthrie would be thrilled. Follow him and try not to kill anyone.
Dr. Warsh, I'd really like to observe that case too.
How nice for you. Waiting for a formal invitation? Go now.
So this is an interesting dynamic so far with the intern, Dr. Pineda. She immediately states, patient needs TPA. She's implying the patient is having a stroke, since the garbled speech, which is possible. It makes sense. Patient garbled speech, you would think it's a stroke. However, let's not jump the gun, intern, right? This is your day one in the ER. The patient needs a CT scan without contrast. They need that stroke CT, and they need a neurologic exam. This early in your training, sure, you can be thinking stroke, that's great, but the mistake is to focus on one thing so much that you exclude the possibility of other things. Patient comes in with chest pain, EKG's abnormal, you're focused on STEMI, it's a STEMI. Turns out the patient's actually having an aortic dissection, not a STEMI. So you want to consider all possibilities here. Now, you're not giving TPA without a head CT and without doing a neurologic exam. Now, she's obviously super excited and wants to show off her knowledge, but jumping right to stating the patient's gonna need TPA without an actual neurologic exam and CT is not good. An intracranial mass, an intracranial hemorrhage can do the exact same thing. Regardless of what happens here, don't skip steps. That's how bad things happen. I cannot emphasize this enough. If they're doing this early on, I imagine steps are going to be missed throughout this episode, and I will critique it every single time.
I need you at dispatch. I got 2 coming in, 1 critical. Dr. Hudson's on his way down now to meet you.
You and you, follow me. Jesse, find something for Dr. Panetta.
Why is she ignoring me?
Because you're the only one who went to school here. It's their first day around her. You need to relax.
I'm not here to relax.
I know, this is your big I'm a doctor now moment.
Kinda, yeah.
Good, because I need a hero. In fact, I'm holding out for a hero to the end of the night.
Loving it, loving the quote.
She gotta be strong and she gotta be fresh from the fight. Don't get shy now. I need a hero. Come on, let's go find you an attending to annoy someone who needs a hero. Looking for a hero?
All right, so far in terms of putting interns with attendings, relatively realistic. I love this. My first day in the ER as an intern, multiple different attendings are on. Some days you work with multiple attendings. Some days you just work with one. You introduce yourself to that particular attending. You obviously hope you have a cool one. All right. They're going to have, you see a patient, sometimes it's going to be a little bit lower acuity just to kind of gauge your knowledge level, your experience level, and then you're slowly going to get more higher acuity cases. That's pretty normal. It's rare that you're just going to walk in on your first day and be like, all right, this cardiac arrest is yours. We're going to see a patient. You're going to staff with the attending. The attending's kind of gauging that knowledge level. Again, that's pretty normal. That's pretty realistic.
Dan?
Dr. Hudson, say hello to Dr. Savetti and Lawrenson.
Neil Hudson, congratulations on matching 2 angels. You're learning from the best.
I hope that was a
You knew
good
what
thing
I
to
said
match
before.
there.
I don't think those things about you.
Yes, you do.
We just have different philosophies.
You didn't always, Dan.
What you got?
36-year-old male, airbag malfunction, non-responsive, head injury, multiple lacs, pulse 65 BP. Area, multiple lacs in the face, head and upper body, with glasses just about everywhere. She is highly agitated.
All right, so what I love about this scene is the stack of ambulances all next to each other. When I go into work, one of the entrances is near the bay, and you can easily tell how many ambulances are present. And when you look and you see them just all lined up, sometimes they're on one side of the road, they're full in the bay, they're lined up on another side, and you're like, man, this is gonna be a long shift. Now, in this case, if I'm hearing this right, something's happened with the airbag. This is an unresponsive patient. I'm not sure exactly on the age of the patient, but we find out he's got a head injury, he's got multiple lacs. Now, I couldn't tell what the vitals were that EMS just stated, but I did hear heart rate 65. So that's interesting. The patient's not in shock, but it could be concerning though if this is like early on, the patient's normal heart rate's 90 and now it's 60. He's got a head issue and the heart rate's actually slowly declining. So that could be an issue here.
Hey, darling, please. No way.
Do you want it straight or do you want doctor talk?
I want it straight.
What's your name?
Ariel.
Ariel. I'm Dr. Warish, and the truth is we don't know why your father's unconscious, and I can't learn anything out here in the dark. So with your permission, I want to take him inside.
Let's go.
And I promise you I will tell you everything I know as soon as I know it. Okay? Okay.
We gotta get going.
Don't ever lie to a patient again. She may be young, but she's entitled to the truth. 1, 2, 3. And careful. Right. Great. Back down. Easy now. Here we go.
All right, so I only stopped here because that ET tube, that endotracheal tube, is so far out of the lungs, it's about ready to fall out. This ET tube is likely just sitting in the back of the throat. Literally, looking at this, there is so like so much out of the mouth. They basically just intubated the mouth. You know, give us the appearance that the patient's intubated appropriately. Just cut the ET tube in half, put it in the mouth, and give us that appearance that it's not right main stemmed, that it's actually not, you know, you're not intubating just the mouth itself. Give us that appearance. Now, I will say they got the patient over quickly from basically the gurney into the ER bed. I love that. But again, the endotracheal tube is not where it needs to be. In reality, what we're doing here is we're confirming that ET tube placement. We're checking bilateral breath sounds. And if we need to intubate or re-intubate, we do that. Now, I told you I'm gonna be picking this apart on every detail. Now, am I gonna get everything? No, there's no way. There's just too much here, especially on dramas where you can clearly tell the consulting physicians were lacking. So far, we are at, you know, roughly, what are we, 11, 12 minutes in so far, and I can already tell you the consulting physicians are lacking on this case. But again, I'm gonna try to get as much as I can.
Both the 30 BP, 60 over 30.
Why didn't you take
Get the juice. Norepinephrine?
Yes, please.
There you go.
All right, so the blood pressure is 60 over 30 and the heart rate's 110. So the patient's hypotensive, they're tachycardic. Clearly this patient's in shock. Now, I'm assuming that this is the same trauma patient that was in the bay. I could not tell, you know, the blood pressure when they first came in, but they mentioned the heart rate was normal. So if you recall, it was in the 60s. So in trauma and in the ER, things can change. Patients can be stable 1 minute and then they decompensate and are in shock the next. So overall, that change in vitals was pretty good.
I'm on it.
What's your evaluation, doctor?
Patient unconscious, low BP, warm extremities, he's in spinal shock.
No additional examination.
It's pretty textbook.
Pretty textbook, huh?
Yeah.
Okay, what about you, Dr. Textbook?
Central line's ready.
All right, so he says pretty textbook with no additional physical exam. Are you kidding me? Just like earlier with Dr. Pineda, I don't know why these interns can think they're so cocky. He can diagnose spinal shock. I'm not even gonna talk about spinal shock without even completing the primary survey or secondary survey. Like, what the heck, dude? You're an ER intern. If you do that with me, you're in trouble. You rotate with me and you just don't do a physical exam and you just give a diagnosis, like you're gonna be in trouble with that. Nowhere in advanced trauma life support, ATLS, does it state to diagnose your patient before even completing a primary survey, before even doing a physical exam. I really hope the attending puts him in his place. Do your complete physical exam and then give me your differential. Do not, and I repeat, do not give me your diagnosis without actually doing your physical exam. Especially, this is an ER intern. Are there times when you can just look at the patient and you can almost gauge what that diagnosis is or what you're suspecting based on what you're seeing? Sure, I get it, but you're still doing the physical exam, right? Let's say you have that patient, you walk in the room, eyes are yellow, they're yellow. Let's say at the time that you're doing the exam, you know, their shirt's already off, you can see spider angiomas, you can see the abdominal distension. You're like, all right, most likely this patient's got some underlying cirrhosis, they've got portal hypertension, they've got possible, you know, portal, you know, gastropathy, they have some type of liver issue. Sure, you can gauge all that, but you're still gonna lay hands on the patient, you're still gonna do a physical exam here. So in this case, you know, don't be dangerous. What this intern's doing is dangerous. Be a good intern, don't be this intern.
Huh? Here you go, needle. Thank you, got it. Is he 111? Yes. Then say so. Trepidation is a deadly quality in this place. Let me out.
Life lesson. When asked if you want to examine your patient some more, it's like being asked if you want a breath mint. The only answer is yes.
I love this. You tell those interns, mama, do that physical exam. Boom. Now, once this patient is stable, I'd be like, get down and give me 50. Not really, but that would actually be pretty cool to do, especially in trauma bay.
How is a 111?
I assume she was referring to the GCI scale. 654 is normal brain function, 111 is the lowest.
He's brain dead.
That poor kid.
I think it's time you called your aunt. She can't get a flight until tomorrow.
I can't talk to her until I know my dad's okay. She didn't handle my mom dying very well.
How did you handle it?
I was only 8, so. Is that lady doctor coming in soon? Someone taking care of my dad?
I'll check. Meantime, here's my cell phone. I'll call your aunt. She'll feel better hearing your voice.
He was confused that I didn't understand it.
Yes. Called expressive aphasia.
Oh, you gotta be kidding me with the backwards stethoscope here. It was bound to happen sooner or later. I look for this literally in every medical drama. Again, we see this all the time, literally every medical drama. Stethoscope is gonna be on one way, and then further on an episode is gonna be on the other way. And I've been told in previous comments on one of my other videos, hey, it's because, you know, they need to be able to hear the lines. The actors and actresses need to be able to hear the lines. I don't know if that's true or not, but regardless, again, we're pointing out what's realistic and what's not, what's accurate and what is not, and a backwards stethoscope is just not cutting it. Now, I'm gonna continue pressing on. I'm gonna do this for all of you watching, but right now, this is getting very difficult to continue with what I keep having to see. This stethoscope, again, kind of ADD side point here, the anatomy of the body and how this stethoscope is, the anatomy of the ear canal, again, when you look at this, you're gonna see the stethoscope is kind of angled one way. When we put this on, it's angled towards the camera. Again, you can still hear with this. You can still talk with this. Sure, it sounds different, but again, it's angled up towards the camera. That's how we wear these stethoscopes. This is what we do. And so to see this, I'm sure I'm going to see it throughout the drama. They're going to flip it back and forth, but I'm going to point it out every single time. Just wear it correctly.
It's word salad. Sounds right to him, but the words come out all tossed around. Activate the stroke team, please. Young Squire, I heard you mention TPA. Is that what you're thinking?
Sides North 4, 8:55 p.m.
Yes. The symptom profile suggests MCA distribution.
I think so too. Fingers crossed. Okay, Mr. and Mrs. Claire, TPA is a kind of miracle drug that has the potential to bust the clot up and reverse the stroke, but only if there's no actual bleeding yet in the brain.
All right, so for starters, they're talking about TPA, and that patient hasn't even been to CT scan yet. Time is brain, time is literally everything. And we're not gonna give TPA unless you have a CT scan that shows there is no contraindication to getting TPA. Heaven forbid they have this intracranial hemorrhage and you give TPA, they die. Some emergency rooms, if a patient comes in with stroke symptoms, they immediately go to CAT scan. Now, they're stating to activate the stroke team, which is typical. Neurology is gonna respond and various other specialists are going to respond. Kind of depends on the level of facility you're at and what you have the capability of in terms of endovascular and all that kind of stuff. But please get that patient to the CT scanner. The PIT actually did a stroke scene perfectly when they arrived. The treatment, you know, obviously when the treatment improved, that's a different story. Watch that critique. But when talking about the patient arrived, they came in, they were in the hallway, they did an exam, they went directly to CT scan. There was no delay. That was perfect. Here, they're talking about TPA. That's great, but get the patient to CT scan and talk about that while the patient's in CT. You're all wasting time here. So TPA or alteplase is a tissue plasminogen activator that converts plasminogen to plasmin, an enzyme that breaks down blood clots. Now, in this TV series, they're talking about TPA. I'm assuming the head CT is gonna be normal and they're gonna give TPA, right? That's what we're assuming, unless there's already a bleed or a mass and they're not gonna give TPA. Now, I will say from when this was filmed, TPA was used for acute ischemic strokes. Now it's more TNK that's been being used within the last year. And so I'm not going to talk about that difference, but you know, if they get into medication administration, which I see a lot in TV medical dramas where a medication is given wrong or incorrectly, I will point it out. I'm pretty scared about what's coming up next. In this case, this patient should already be in CAT scan, or at least going to CAT scan. They just need to stop talking about, you know, TPA. Just get them to CAT scan already, but we're going to continue.
We're gonna need a scan to know for sure.
It doesn't take 12 people to run a scan.
Ooh, that was a close one. So he's getting a CT scan. I was about ready to lose it. I was like, this patient needs a CAT scan. I understand the ER is busy and they're probably trying to portray that. The busy, you know, the ER is so busy, the CT gets delayed, maybe again, staffing issue. I suppose I'll give a little benefit of the doubt in this case based on that, but at least they're going to CAT scan.
Young Squire, would you check in at the nursing station, see where you can be useful?
When they're done x-raying him, take him down to sides and put a cast on him. Are you good?
A cast, that's it?
This one.
Oh, you got it. Wait, where is x-ray? Let's just keep that between us, okay?
He's brain dead.
Oh, God. She's all alone till tomorrow.
Has someone called called Child and Family Services to come get her?
Yeah, but you know how that goes. It could be ours.
It gets worse. He's an organ donor.
They state the patient is brain dead. This is referencing that car crash individual. I feel like this scene is so unrealistic. One, they shouldn't even be saying that. And I feel like it's so unrealistic, it's not even worth my time. You know, did they consult neurology? Did they do a brain death protocol in the ER? One, it shouldn't be done in the ER, but did they even do a brain death protocol, right? And it's all been within 10, 11, 12 minutes right now. So this is not even realistic. Like, what is even happening here? I'm not even going to be talking about the nature of a brain death protocol and the requirements and consults that goes into this. This part of it is just, it's not even worth my time. This is not even done in the ER. And again, if you want to hear a lecture on a brain death protocol, check out my critiques on The Pit, because I talked about it in detail. They at least did a few more things with this, and it wasn't within this 15-minute window of showing up to the ER. Clearly, you know, this is going for more entertainment here than it is medical accuracy, because with this, there is 0% medical accuracy within this scene when they say the patient is brain dead. Like, come on, guys. Like, what are you doing?
Transplant team's on the way.
Then we can't wait for CFS. I have to tell her.
Neil. I should do it.
Why? She's my patient.
I gave her my word.
I don't think it's a good idea. It won't be pretty.
So this is basically just getting to be entertaining at this point. You have a motor vehicle crash, heart rate was 60s initially. They get him in the trauma bay, right? They're hypotensive, they're tachycardic, they are unresponsive. The pupils are fixed. There's no CAT scan of the head. Actually, they discussed nothing regarding, you know, what meds did EMS give before they intubated, right? Was before they intubated his mouth. Was rocuronium given? And the patient's actually still paralyzed, and that's why nothing's happening. They completely ignored, obviously, a brain death protocol. They didn't perform a head CT. They didn't consult neurology. They literally labeled him brain dead within this 10 to 15 minute window, or however long it's been at this point. And then, you know, they find out he's an organ donor. They call the transplant team. The transplant team is on the way. Like, what? I don't understand what's going on here. Man, I just don't want to continue anymore. I just can't do this. It's like, honestly, I think I'm stopping. Like, this is crazy.
You awake? Ariel, your father came in with some terrible injuries, most of which we couldn't see at first. What are you saying? There is no good way to say this. I'm sorry.
What?
We couldn't save him.
I don't understand.
Your father died, Ariel.
Well, technically, it's a brain death.
So he's not dead?
No, that's... What I mean is, machines are keeping his body in a state of...
What are you saying?
I'm trying to explain to you.
No, you're not. What happened to just giving it to me straight?
I'm giving it to you straight.
So he's dead, but technically not really, right? No, I want to go see him. I want to see him. I have to see him.
Sit down, please sit. Listen. No. Ariel, your father chose to be an organ donor. That's why we have machines keeping his organs functioning. You have to understand, he's never going to wake up. He's gone, sweetheart. You're terribly sorry.
I do love the bedside manner of this ER attending. It's very good. I love it.
No. You can't have his organs. I have his daughter and I'm saying no.
Well, unfortunately, that's not your decision to make. It's your father's, and he made it alone.
No, you don't care about my father and you don't care about me. You just want to cut him up.
Ariel, that is not true.
Shut up. Shut up.
Sorry. I'm so sorry.
so overall, we are 16 minutes in this episode, and Dr. Rorish, the residency program director, performs a futile and inappropriate procedure in a hemorrhagic shock patient in cardiac arrest. This was not indicated, it was not approved, it was not recommended, it's actually not going to help the patient. You know, she literally did the wrong procedure, that in reality, the patient would have died with that procedure. You may be saying, well, it's a last-ditch effort. No, you don't understand. It's a futile procedure. The patient would have died doing this. You have a greater chance of doing some of the other things we talked about than doing this procedure. And now the scene of a reported brain death within 5-10 minutes of arrival to the ER, none of this is accurate, none of this is realistic. I expected more out of this pilot. I expected more out of a residency program director. Like, you lead all the residents. You literally lead them. You and the faculty are responsible for this education. And she gets this bizarre idea to replace all of the patient's blood with saline. Like, are you kidding me? What is this? I would question the medical knowledge, the accuracy, the skill level of the residents coming out of this program so far, because with what I'm seeing, it is scary. It's moments like these where everything almost becomes a blur, everything kind of slows down. All right, so you can tell she's exhausted here, and I think the writers are really trying to show that side of emergency medicine. I get it, but to fall in love with Code Black, to fall in love with Dr. Rorish, to really fall in love with wanting to keep watching this, the medicine has to be there, the accuracy has to be there, and it's not. With The Pit, you immediately fall in love with Dr. Robbie. It makes you want to keep watching the episodes because the accuracy and the realistic part of emergency medicine was there. Dan, can you just check how many seasons? I meant to look that up. I know there's at least one. I think there's 2, but I don't know if there's any more than that. I guess the big thing at this point is I could see potentially non-medical people loving this so far, but if you're in the medical field and you're watching up to this point, I guarantee you are shaking your head with all of the medical inaccuracies of this. There's just no way there's more than 2 seasons of this. What do you got?
It says here it went for 3 seasons before being canceled.
So it doesn't surprise me. So I think the big thing with this is that, yeah, we made it season 1, season 2, season 3, but now I question, who are the consulting physicians? Were they consulting ER physicians? Did they consult any physician at all? I think there was so much potential with this pilot, so much potential for a good series. It's just disappointing so far. Again, I'm continuing just for this critique, but this is very difficult to keep going.
Well, you qualify for TPA and we're still inside the window for it to be effective.
What are the complications?
Only 7% experienced the miracle. However, the same number experienced catastrophic bleeding somewhere else in the body. We wouldn't know where until it was actually happening, and we might not be able to stop it.
And if we do nothing?
What you see now, and possibly worse.
So I'm glad we find out now that he's a candidate. That's the big thing with this, but we should have known sooner that he was a TPA candidate. That patient should have been CT scanned a long time before, he actually got there. Remember, time is brain, time is literally everything. Time is testicles, time is ovary, time is brain, time is heart, time is everything. The quicker we have that CT back and it's negative, the sooner we can proceed with those thrombolytics like TPA or what we give now typically is TNK.
Whatever you're doing, log out, follow me. You're gonna love this.
Sounds exciting.
Clearly, you don't speak the native tongue of my people. Sarcasm. Come on.
Hey, come on. Hold your arm up, just like
Angus.
this.
Yep. Guthrie wants you here with the stroke patient. Would like to finish the cast.
Wait, Guthrie's gonna let him administer the TPA? And I'm gonna do a nurse's job.
A nurse's job.
I didn't mean it. I didn't
You want to
like
be
that.
part of a team, Elia. No job is too big, no job is
She
too
should not be
small.
saying
Dr.
nurse's
Lane,
job. Do you know how many of these splints I put on as a resident? Like, yes, nurses do those. Yes, techs do those. Residents do those. Attendings. I did a few of those even as an attending. So
Wait,
that's
what's up with
like she doesn't need to be saying that. That's crazy.
Just sleeping it off.
Great. Go. TPA has a short window.
How soon will we know if it worked?
Just takes a few seconds when it works.
No, it does not. It does not work over a few seconds. Also, nurses give this medication, not doctors. I see this so many times in TV medical dramas of doctors giving medications that a nurse would give. Over my career, I've probably had, 50, 100 plus patients that have received TPA. How many did I actually give the TPA myself? 0. Doctors don't do that. And for that reason, this is 100% not realistic. You may say, Dr. Taylor, well, they're short-staffed. No nurse is available to give these medications. The resident had to do it. No, that's still a no. The nurse is going to give this medication. We all know that this was not the issue here, right? They wanted the resident to do it. They wanted the intern to do it. They wanted a more dramatic effect.
Come on, baby. Show us the magic.
It does not work that way. Unless the patient had a TIA and you actually gave TPA for a TIA, that is the only way for this to happen. You know, if this is an MCA infarct, this is a large vessel occlusion, legit stroke, and you give TPA, it does not improve like this. Seriously, who are the physicians consulting behind this? I want to know. There is no way that these are full-time practicing emergency physicians. 100% not realistic. This is disappointing.
Mr. Cleary, I want you to try and speak.
Love you. Yeah.
That's sweet, but that's not how that works.
Abracadabra. That's why we're here, young squire. Never forget that.
All right, so this is a great moment, but it's not realistic. No nurses in the room. The doctor's pushing TPA with an immediate response. Nope, that's not true. Strokes do not improve like that, but we see this in medical dramas all the time. Now, on another note, you notice he's pushing TPA. Now, they're not even given the medication right. I spoke about this on the pit when TNK was given for a stroke, because TNK is now approved for acute ischemic stroke, and many ERs are now turning to that instead of TPA. But in this case, you know, this was a number of years before, like I mentioned previously, and so at the time, TNK wasn't FDA approved, so TPA, that's fine. There's nothing wrong with that. It's just the medication is being given wrong here. Basically, the attending and the resident are incorrectly giving the medication. If you've been watching all my pit critiques, I'm going to point it out every single time a medication is given wrong. So how do we normally give TPA? So it's given, the stroke dose anyway, 0.9 milligrams per kilogram, not to exceed 90 milligrams whole treatment dose. We actually give 10% of that as an initial bolus over 1 minute, the remaining over 60 minutes. You'll notice if they bolused 10%, right? 10% of that initial bolus, which we know they didn't. You give 10% of the initial bolus, and then you're going to give the remaining 90% over 60 minutes. What they do, they just slam the whole thing. And so that's just not realistic. It's not going to work. Now, in the case of a cardiac arrest secondary to a pulmonary embolism, it's a little bit different. You know, are we in the middle of an arrest? Do we have ROSC? There's more factors at play here. The dosing's different. You know, are we doing 50 of TPA and we're doing CPR? Another 50, is this, you know, the FDA approval for TPA post-ROSC, right? All these are different, but we're talking about ischemic stroke in this case. Now, we spoke about Dr. Rorish and her education, and now we have this attending, right? It's not just one. It's like the second one now. This attending, letting the resident give a medication incorrectly and then telling him basically, it takes a few seconds. No, it doesn't. Wow is all I can say. Wow. Would not recommend training at this residency at all. I don't know if this was like last resort residency. Like, you know, when you rank your residency programs where you want to go, there's certain programs that you're going to rank higher. There's certain programs that you're going to rank lower. Like, was this a last resort residency? Like, people went here because they got rejected everywhere else. Because now we're 2 attendings in, we kind of get to see some of their teaching style. And even now, this one is saying wrong stuff. Like, where did he learn it at? So many questionable things here.
breathing labor, possible allergic reaction.
You didn't eat or drink anything out of the ordinary.
Where are you from?
Norway.
Center stage.
So this is an interesting case to start with. It's a 10-year-old coming in, labored breathing. EMS states possible allergic reaction, so that's cool. This can go a couple different ways. We learned they're from Norway, and the parents note the child did not eat or drink anything different than normal, so I'm not sure exactly where Norway is going to play into this.
Your son has a collapsed lung. We're going to help him.
How could you know that?
If a Norwegian kid can't breathe, it's a pneumothorax. It's a genetic predisposition. Can someone run another IV for me, please?
I'm all out of nurses.
I got it.
My girl.
Okay, watch his head.
It's a pneumothorax. Seriously, come on. Genetic predisposition or not, the residency program director literally stated it's a pneumothorax without even listening to the lungs. Like, are you kidding me? No attending in their right mind will just look at a patient and say pneumothorax. That is inappropriate. You don't do that. You do not jump to a diagnosis without even listening to the lungs. Now, had she have listened and heard absent lung sounds, and she listens and says, oh, diminished lung sounds on the left, and said, I have a possible collapsed lung, I would have believed it. But to state, you're from Norway, you're short of breath, you have a pneumothorax, without actually listening to the lungs is messed up. Literally, I want anybody watching this to realize what she did. She didn't even get the rest of the history. She did not even listen to the lungs, and she states pneumothorax. Now, the case started out pretty good, and then it just got ridiculous. Like, I'm really starting to gauge this hospital has some great cases. They have some awesome cases so far for learning, but hearing what the attendings are doing, how they're teaching, I would not want to train in a place like this with attendings that teach like this. Like, this is so dangerous. At the end of your medical school, you're on the residency trail, you're interviewing all these different programs. You're going to find out which residency programs you like, which ones you don't like, and you're going to have this rank list that you're going to submit. Who's your number one, and then all the way down, number two, number three, etc. The programs are going to do the exact same thing, and you're going to get matched up. Hence, it's a match. And so this would be a program, again, I would have probably not ranked, or it would have been last. Like, it would have just been way down on the list. Likely, I probably wouldn't have put it on the list. There was a few that I interviewed at that I did not put on my rank list. I did not submit those because, you rotate there, you kind of do this, you do this interview. Let's say you're there for like a couple shifts just to kind of gauge what's the dynamics of everything, the teaching. You really try to really immerse yourself in that program to say, could I see myself here for 3 years? Could I see myself here for 4 years? That's what happens. That's normal. This would have been a program that I would have not likely ranked at all.
Back him up, back him up. What's your son's name?
Basti, short for Sebastian.
Okay, Basti. Thank you.
Come on,
I
guys.
need you to look at me. Step it out. You're gonna be all right. We just need to let a little air out of your chest. You're gonna feel better right away.
Leanne, Charles team just took care of us father upstairs.
Understood. We're gonna put a tube
Can I have a gel, please?
into Basti's chest to relieve the pressure. This is very routine. We can do it right here.
So I'm just getting annoyed with Code Black. I think, at this point, Dan, I'm just going to take a brief energy drink break. So this is one of those for, those watching, you don't like energy drinks, pretend that was just water. That's totally fine. This is one of those that I am persisting for you guys. It takes a lot of energy to keep through this. I'm starting just overall just to get annoyed by Code Black, but again, I'm going to keep going. Even if she now listened to the lungs, said diminished absent breath sounds, we hear no mention of any vitals. Like, the patient looks calm, there's no distress. Is this a simple pneumothorax? Is this a tension pneumothorax? Doubt it. Given the patient presentation, Dr. Rorsch literally grabs a chest tube and states they're going to put in a chest tube in the chest without actually doing imaging. Seriously? No x-ray? Now, if you say to the patient was hypoxic, tachycardic, no lung sounds, if you gave me a set of vitals and then you stated you were going to needle decompress without an x-ray, perfect. That's what you do for a tension pneumothorax. You should not diagnose it at all on an x-ray. That's a clinical diagnosis. But overall, none of that was mentioned here. An ER attending in real life is not going to place a chest tube on a stable patient with a suspected pneumothorax, and they never obtained imaging. Are you kidding me? Now, they could say, oh, it's just because the ER is way too busy. We can't do x-rays. There's not even a set of vitals here. And they didn't even listen to the chest until later. Also, you're gonna notice here, she's handing over a tube. This is a chest tube. I cannot tell what size here, but I can already tell you that is too big of a chest tube for that patient. I feel like I need to pause here and just do a bunch of education on chest tube sizes, proper chest tube sizes, discussing pigtail catheters, because this scene is 100% not realistic, but I'm not going to. I'm going to save that review, for medical dramas that have at least chosen the correct tube size, like The Pit, for example. Certain, medical dramas are actually worth my time. This is not one of those. The Pit, on the other hand, is absolutely worth it, and I talked about chest tubes on The Pit. Who are the consulting physicians behind this episode? You would not even use that kind of chest tube in this situation. It's actually going to be a pigtail catheter chest tube. I'll even put that now on the screen for you. For starters, this patient needed a pigtail catheter chest tube, not a large bore chest tube. Even if they said, we have no more pigtails, we only have these chest tubes. Okay, that's fine. You justified it. But remember, you're putting that chest tube between the ribs. Literally 2 ribs, you're putting the chest tube between it. Obviously, the smaller you are, the gap in between your ribs is going to be smaller in general. This tube is so big, if they tried to put it in, you may even bend those ribs. This is just so fake, and it's just gonna be painful. This is, what are we, 25 minutes now into this, and it seems like it's been forever. I think just more of an energy drink, at least at this point, but we will continue.
She has to talk to you.
Me? Why?
She connected with you.
No, she didn't. Nurse. Angus, you're gonna do the chest tube.
I'm gonna do tubing.
Me?
Yes.
He's getting a little touchy, Doc.
Buddy, here we go.
What are you doing?
I'm looking for my diploma to make sure it's really my name on it. I'm prepping a tray for you. You're going to be making an incision.
Yeah, I can take this case. Go and talk to her for a
Look,
minute.
Miss Woman, be a social worker. You get the patient as you die in the waiting room.
She's a patient too, Leanne. Go and talk to her for a
Look
minute.
around you, doctor. We're about to be in code black.
I have eczema, itches like crazy. You don't care, right? These people here, they don't care about your problems either.
All right, Sebastian, I want you to slow your breathing down, okay? Can you do that?
No, everyone stop. Let's get a set of vitals, please. No, you are not cutting into that chest. Someone page Dr. Taylor. I'm going to take over this case. It's going to be done correctly. If we do, in fact, have a pneumothorax and her guess was correct, without an x-ray, without a set of vitals, that patient needs a pigtail catheter chest tube. That chest tube looks massive. I would not even want that in my own chest, and I doubt that chest tube would actually fit between those ribs. It's just too big to begin with. Someone page Dr. Taylor, not this dangerous Dr. Rorsch. I can already see why this TV show was canceled after, we said 3 seasons, is that right? After 3 seasons, and that's because likely the medical community went nuts with the inaccuracies. That's my guess on that one. Again, you want to start going 4, 5, 6, 7 seasons, you better have, an ER doctor team behind you. I can see why this was likely canceled after that 3rd season.
What's that kid doing in here? Is he okay? Whose patient is this?
Somebody needs to help this kid. Clearly, they missed something here.
This kid has a head injury.
All right, so the kid with the fracture, if you remember, he went to the front desk, he checked in. Later we hear about an x-ray and then splinted, but we didn't actually get to hear the history and physical exam. I assume that happened, or they were just so busy it just, it didn't happen. Did he get, did he hit his head? Was there any loss of consciousness or LOC? Now, he was high, on something and joking, around. So when he came in, did that kind of distract the healthcare workers a little bit? Did they not properly evaluate him because of that? Was it missed? They likely didn't obtain that entire history and physical because they were distracted. Oh, he's talking, he's joking, he's high, he's fine. And they didn't actually do a neurologic exam. A history of what happened would have revealed likely he hit his head and potentially passed out. This is scary. This was missed. This ER is busy, I get it, but it still does not mean you skip questions, you skip an exam, because things can be missed.
I gotta pull somebody out of here. We are officially in code black.
All right, that TV medical drama point when you physically have no space, resources, staff to be able to function when you're over max capacity, that is what the TV show is trying to show us, but obviously it's grossly dramatized and filled with horrible medical inaccuracies that I've already mentioned. The Pit, that gives me PTSD because The Pit is hard to watch of how realistic it is. I would argue Code Black is easy to watch. There's no PTSD with this one. I get no flashbacks because Code Black is 100% not realistic. It's filled with medical inaccuracies. If anything, it just pisses me off that I cannot be in the ER medical drama. I can't be in this drama. I can't be in this ER to help out and make it realistic and accurate. So much potential was lost in Code Black. Now it's pointless to try to rejuvenate and bring back Code Black, because now you would be competing with the greatest medical drama of all time, The Pit, and that's just not happening. Like, you just can't compete with the accuracy of The Pit. It's amazing. I love it, and you can't put Code Black on the same level as The Pit. It's just not going to happen.
No, I know it is. But I need a neurosurgeon down here right now.
Hang on, pal, right there.
I think it's an internal bleed, Natalie.
All right, so they try to set this up that neurosurgery is completely busy. The attending neurosurgeon can't come down. I think I know where they're going with this, and what they're trying to show us is the classic epidural hematoma. The classic case that we often see on the board exam, med school exams, is literally a patient that takes a hit or a fall. It's the baseball to the head is the common one that I see in a lot of board exams. Initially, they passed out. All right, and then they have improvement in mentation for a little bit. Everybody's a little bit different, perhaps, or even talking. We call that lucid interval. It's that period in the middle. And then all of a sudden, they decompensate. They go downhill. Now, that's the classic story of an epidural hematoma. So the patient was likely in that phase if they're going with this. It wouldn't make sense for this to be a subdural or a subarachnoid. If they're going for this mental status change, every time it's going to be an epidural hematoma in a TV medical drama because it's exciting. The only thing this patient would need at this time would be a burr hole, literally a hole drilled into the head to relieve the pressure. Now, would I buy that this ER would attempt it? Maybe, because so far they seem to just do anything, even though, it's wrong. They just literally do anything. But do I think they're going to do it correctly? Haha, no way.
Okay, wait. Before you continue, what would be your guess?
So my guess would be they're going to, assuming this is an epidural, they're going to do the burr hole and the patient's magically going to get better. The neurologic exam is magically going to improve. That's what's going to happen. That's my guess.
CT scan is ready. All right, great. Let's move in the chest tube, right?
Yeah, it's about to start the incision.
Wait,
Let's go, Jesse.
wait, you're gonna move? You're leaving?
This patient needs an MD and we're in Code Black. I think you can handle it.
Let's go, let's go, let's go, Jesse.
Can he though? Can he? All right, so this is great that Dr. Rorsch is accompanying this patient, and I see a cardiac monitor, which is totally fine, but the patient's clearly unresponsive. And up to this point, since the patient collapsed, I've heard nothing on a mental status. Does this patient even have a gag reflex at this point? Does he need intubated at this point? Literally, there's been no mention of it. Where is the neurologic exam? I'm confused at what's going on here.
Still got diminished blood pressure. Great. Hurry up.
Now, I may just have to fast forward this scene. I hate that he is cutting into the chest. I did not expect to critique this, but even if you choose to put in a regular chest tube instead of a pigtail, the incision he's doing is wrong. When we place a chest tube, the proper position is the patient sitting up. Typically, it's a 30 to 45 degree angle every time. And the arm is above the head. The intern's literally making the incision wrong, and nobody's saying anything. Literally, wrong type of incision, wrong angle, wrong spot on the patient, wrong position of the patient, and frankly, it should be a pigtail. Seriously, who are the doctors behind this? If you're going for entertainment value, sure, watch Code Black. If you're going for medical accuracy, if you're going for realistic ER medical drama, when they adapted this essentially from the documentary, to trying to make something realistic, it's just not happening. It's just not there.
Stabilizer's taken. I'll be doing ready. All right. Tube is in.
Vitals are dropping. Doesn't make sense.
Hang in there, pal, okay?
Why isn't it working?
What is happening?
Probably because you put it in wrong. Literally, you shoved it in, probably damaged other organs, you perforated something. Legit, you just put it in wrong.
This one's just stuck. He's breathing down.
I cannot talk about the chest tube anymore. It was done horribly. Literally, he just shoved it in. When we do this in real life, after the incision, the correct incision, we actually do a blunt dissection. We then take a curved Kelly that was, that allows us to puncture through and create a tract into the pleural space. We then gently place the chest tube. We angle superior toward the top of the lung. Obviously, it's a different situation. So if it's a hemothorax, if it's a pneumothorax, again, we're aiming towards that top of the lung. Here, the intern is literally just shoving the chest tube in like mad. Like, this is crazy. This is 100% not realistic. Or is it realistic? It's just a horrible residency program, right? This is horrible to watch overall. Now, if you do it this way, you're gonna have some damage doing this. You're gonna have complications doing it this way. If you watch my critique on The Pit, I believe it was episode 8 or 9, one of those, it was correcting Santos and how sometimes you have this resident doing something that potentially could harm or injure a patient. You want to say something to have them stop, step back, step aside. This is one of those moments. Somebody needs to say something. Dude, the position of the patient's in the wrong spot. Your incision's in the wrong spot. Like, you're shoving it in. Like, please stop. Like, what is going on here? Somebody please stop him, or at least page me. I will take over this patient, please.
Please do something. He's not breathing.
Angus!
Stuck in the fascia. Get him out of the way. Grab the tool. You need to pull.
He's standing, Jesse. We need to get a doctor in here. I'm a doctor, and you are too. Listen to my advice, okay? Do you feel it?
Yeah.
Just stuck in the fatty tissue.
Okay.
Seriously, stuck in the fatty tissue? That makes no sense. We literally watched him shove the chest tube in through the hole, and he kept shoving, meaning I could tell you he was already in way too far. Like, he's probably in the pleural space, just way too far, poking other things in there. It's just horrible. But now they want to say he's in the fatty tissue. That makes no sense. So if that was truly the case, he would not have been able to place as much of that, chest tube in the chest on screen that we got to see. Whoops, they screwed that part up. Also, if you blunt dissect with your Kelly clamps like you're supposed to, you would have had a track for the chest tube to actually go through. This entire scene's a joke. This entire scene is 100% not realistic. The show came out in 2015, which is when I graduated medical school and started intern year. Writers, producers, even if I could have helped you write that scene at that time, it would have been done correctly, and I was an ER intern. So I don't understand what's going on with this. Again, is it possible you put the tube in the track, you don't quite get it in the track? Absolutely. If you don't get that blunt dissection, or you don't actually puncture all the way, or you puncture too small, you're kind of putting your finger in there, you're kind of creating that little area that you can put that chest tube in. Sure, you can start sliding the chest tube in and it won't be in the pleural space. It'll start going one way or the other within that tissue, but you're not going to be able to keep doing this. You're going to be like, no, it's not going in. And then you're going to redirect it. You're going to, create a little bit bigger hole, and then it'll slide in. So to see the scene of him just shoving the tube in and then all of a sudden, it's in the tissues, that part of it just doesn't make sense.
Good chest rise. Good job, Dr. Daniel. Your little boy is going to be okay.
I need a 3 of nylon. Some inclusive dressings. Thank you. Thank you.
Rorish is looking for you. She canceled the talk screen on your Prager. Patient left anyway. Sorry.
Dr. Rorish, I know you're angry. Deliberately ignored direct instructions from your supervising physician. You said trepidation is a deadly quality. I thought I was acting in the best interest of my patient. You don't have patience.
Whoop, whoop. This is what I wanted to see, right? Initially, I was like, are they going to do a burr hole, for example, without a CAT scan? Are we actually going to be able to see a CAT scan up an epidural? That's what I wanted. So an epidural hematoma occurs as a result of blood collecting between the skull and the dura mater. And most commonly, that's because of a tear in that middle meningeal artery and it just bleeds. Now, what's kind of cool about this, you're going to notice here, the epidural hematoma is on the left side of the head, and that has to do with how the patient goes into that CAT scanner. So this is a left-sided epidural hematoma. Again, love the CAT scan, perfect CAT scan. I'm going to go ahead and just put a bunch of those on the screen for you. You can see a left-sided epidural hematoma, a right-sided epidural hematoma, and I'll even show you kind of a few other bleeds as well to kind of compare it to like a subarachnoid hemorrhage or a subdural hematoma, and you kind of see the different location.
You're a first day resident, which means every patient you see is my patient. If I can't trust you here, I can't have you here. Goodbye, Krista. Wait, what?
Go home. It's over.
Go home, it's over. You may be the residency program director, but that's not how this works. She's an intern on day 1 of the ER. This is a resident that, you need to have a conversation with, but this is not an intern that's fired because of this. If this logic was true, then nearly every resident, with the exception of probably Dr. King, would have been fired on the pit on day 1, including Santos. She wouldn't even have made it that far. This is not how that works. So already it's not realistic here at all. Even small things like this in Code Black, they get wrong. Like how? Like, I don't understand. In reality, you're not doing this to an intern. You're just taking them aside. You're talking with them. Not on day 1, you're gonna be like, you're gone. That doesn't make any sense.
She fired me.
Did you tell her I knew?
No, Mario, but thanks for the concern.
Look, I'm sorry, but while you're busy picking out preschools, I paid for medical school, driving a truck, choking on diesel fumes.
Wait. Diesel fumes. Oh my God.
What?
What if it's carbon monoxide? Carbon monoxide poisoning can mimic flu symptoms. She said she lived above a boiler room, right? Oh my God, Mario, I could kiss you. But not really.
All right, so carbon monoxide definitely has some symptoms that are flu-like. That's pretty classic, but it also has symptoms that are not flu-like as well. But overall, some of the symptoms can include headache and confusion. Obviously, it depends on where you're at in the process and what your levels are, but headache, confusion, seizures, vomiting, shortness of breath, tachypnea, breathing fast, chest pain, just to name a few. So it's great on the intern for picking up on this case. I love it. Dan, I guess, what happened with the rest of this, or where are we at? It feels like I'm missing something.
Yeah, I wanted to skip ahead for the sake of time. I figured you'd react way more to the scene that's coming up.
All right, so that works. So, definitely a lot of suspense there. We're going to keep going with it.
Truck ran right over his leg, broken at least 4 places. Big mid-femur deformity from the crutch.
What's your name, sir?
Wayne. Just can't feel my leg, dog.
Buns are pinching him now. We're gonna help.
The truck ran over his leg, crush injury, reportedly broken in at least 4 places, mid-femur deformity. I like how we often see in medical dramas EMS stating how many places the leg is broken. There's no way, for starters, for EMS to know it was broken in at least 4 different places, and that's also not their job to state it's broken in at least 4 different places. As an EMS medical director myself, for my Air Force base, I will critique any EMS report I see on screen. We need to know vitals. We need to know the mechanism, the pertinent history, the physical exam, including, you can add in there if there's a deformity. But if you're going to say that, you're also going to state what's the neurovascular status, what meds were given. That's it. A good EMS report is 1 minute or less. For EMS in this case to state, it's broken in at least 4 different places is impossible to know, and it's not realistic. We also hear the patient states he can't feel his leg. At this point, I'd be worried about vascular compromise or vascular damage. Developing compartment syndrome would be highest on the differential, at least at this time. Dr. Rorsch is almost like Dr. Santos, just grown up and somehow still has a medical license. If you recall, the CAT scan on the screen earlier, right? That epidural hematoma was on the left side of the head. It was a left-sided epidural hematoma. When you look at the CT image on the computer, the right side of the computer is the left side of the head and vice versa. That's how that is. And it's also based on how that patient, it goes into the CAT scan. This is a left-sided epidural hematoma. Here, Dr. Rorsch appears to be getting ready to do a burr hole, literally drill a hole in the head to relieve the blood, only she's setting up on the right side of the head. Hello, Dr. Rorsch. You are about ready to drill a hole on the wrong side of the patient's head. Oh, please let the pain stop. So many medical inaccuracies, it's ridiculous. And now she appears that she's going to start drilling a hole on the wrong side of the head. Are you kidding me right now? Really? Seriously?
IV fluids, 20 milligram morphine stat.
Oh man, 20 milligrams of morphine stat. No. At least give us a set of vitals. Now, we normally give 2 to 5 milligrams of morphine in cases like this, 1 milligram of Dilaudid, sometimes even 100 mics of fentanyl, but jumping right to 20 milligrams of morphine. I can already tell you, no ER doctor is gonna do this on arrival. This much morphine at one time, let alone I repeat, any ER pharmacist, they're not going to approve this at all. And you try to order 20 milligrams of morphine, your ER pharmacist is going to come up to you and be like, are you sure you want to do that? Now, if you want to give 4 to 5 milligrams of morphine and reassess pain level, sure, that's completely appropriate. But don't literally drop that Thor hammer of morphine on them. Even if the patient tolerated opiates well, they were on opiates as an outpatient, they have a history of chronic pain, they're used to opiates, no ER doctor is still going to give 20 milligrams of morphine at one time.
What's that for?
Renovating the suture room.
We're drilling a burr hole? It's got cold. There's no pulse down here. We've got to get this leg straight.
Okay.
I'm going to need that gurney.
Got it? Bring it in.
Over here.
Can't put a hole in that kid's skull in the ER, Leanne. You need a neurosurgeon.
There's an epidural bleed. He's out cold. I got to drain it.
1, 2, 3.
Sometimes you just got to be a cowboy, Neil.
Sometimes you have to be a cowboy. At least cowboys get it right. You're literally going to drill a hole on the wrong side of the patient's head. That is not being a cowboy at all. That's reckless and medical negligence. Welcome to your next lawsuit. Even if that burr hole is done perfect, you will save nobody. It's on the wrong side of the head. Congrats, you are drilling a hole on the wrong side of that patient.
Hey, you're going to need some help if you're going to yank that. Mario, get over here.
Okay, Wayne, this is going to help with the pain.
Dr. Rorish, you might not be surprised by this, but one of your residents is calling you from the back of an ambulance on the 101 freeway. Yeah, Blondie. I gotta go.
Krista, Dr. Warren, it's definitely carbon monoxide. They had to break all the windows. She's still unconscious. We're giving her oxygen. I'm sitting here.
Deep breath. Give me vitals.
Pulse pain at 120, BP 60 over palp.
Our patient's crashing.
She's pregnant. You need to get her back here. She needs a hyperbaric chamber.
Krista, what's your ETA?
Not soon.
You're not going to like this, Neil.
She has to perform a C-section on the rig. Sometimes you've got to be a cowboy, right?
Let's do this.
Chris is going to do a C-section. Mario, focus. I need you up by his shoulders to give me leverage. We're going to try and save this leg.
Listen.
No, this is 100% not realistic at all. Seriously, what is this? What am I watching here? I'm not even going to critique what is happening here. It would be a waste of my time. I will, however, comment on the carbon monoxide, as I see quite a few of these cases. Carbon monoxide is this colorless, odorless gas. It has a binding affinity to hemoglobin 200 times that of oxygen. That is a classic board question. The higher that CO level or carbon monoxide level, the more severe the symptoms are at presentation. So if you get to the point that you're unresponsive and hypotensive, which we learn here, the patient is likely near a cardiac arrest. That's how bad that is. The treatment is essentially to overwhelm those receptors. If we place that patient on room air, this is always my pimp question that I'll give some of the med students and residents in terms of, what is that half-life? If you place them on room air, or the half-life of carbon monoxide is 5 hours, 100% oxygen, 1 hour. Hyperbaric chamber, 20 to 30 minutes, which is exactly what the patient needs here. But again, this is a TV medical drama. This is 100% not realistic. I'm going to keep going. We're going to keep doing this. I am so close. We're approaching, it looks like 32 minutes and 28 seconds so far. So we're going to keep going. We're going to keep doing this.
I need you to tell the medic to prepare an emergency surgical kit.
Wait. I can't do this.
Yes, you can. You've done
No,
an
you
OB
can't. You
rotation.
can't do this.
You've witnessed plenty of these.
Take a deep breath.
You have done an OB rotation. This implies either the 1 month she did OB as a medical student, as that's a required rotation, or the 1 month she did as an intern, literally 2 months max total. Assuming this was not July and they had a few other rotations in there of other specialties prior to rotating for the first time in the emergency room, that's her only OB experience.
Krista, make sure the patient stays unconscious.
No danger there. Okay.
Get ortho ready to go. My friend Wayne here's going to need an OR right after.
After what?
Lab.
Susie, need you on his pelvis. Make sure he doesn't slide. Jesse, need you over here for a sec.
Whoa, BP dropping. Jesse, get back. I need Jesse back, damn it.
Everybody ready?
Ready for what?
Hold them.
One, two,
three.
Pulse is dropping.
Okay, well, then we gotta move fast so have a chance to save both of them.
Krista, I need you to start with an abdominal incision, beginning at the umbilicus and straight down to the pubic symphysis.
I need a cleanup.
You need to cut through all 5 layers of the abdominal wall, including the peritoneum. Get this cleaned up.
What is that noise?
Ignore it. Vitals?
Pressure dropping. Pulse 30.
It's okay. Stay focused.
Start your incision now. Krista, right under the abdominal wall, you're going to see something shiny. That's not the uterus.
It's It's the bladder.
Careful not to nick it. You're going to want to reflect it distally. Get it out of your way.
Okay, vitals are dropping here.
Yeah, I'm almost there.
Leanne?
No, almost there.
Okay.
Can find it.
Pulse is dropping.
Leanne, he's herniating.
I know, almost.
So when I hear the word herniating, what that means is that the buildup of blood in a confined space is shifting the brain. What can happen is that the blood pressure increases, the heart rate goes down, and they eventually go into cardiac arrest and they die. So obviously in this case, the burr hole will work, but in real life, the hole was drilled on the wrong side of the patient. The patient's gonna die. Like, this is gonna be a lawsuit. Like, this is not gonna save anybody at all. So congrats, you just drilled a hole in the wrong side of the patient's head.
Oh, hang on. Hang on.
Is he draining it?
Got it.
Okay.
Okay, get it.
Heart rate's normalizing. Pupil reacting.
All right, Krista. Time to make the vertical incision in the uterus.
Watch the lateral vessels.
Oh, God. Oh. Okay. Now, it's gonna happen very quickly. I want you to reach your hand inside as fast as you can. Carefully. Feel for the baby. When? Have you made the cut yet? Yes. Now. All right, I think I can feel it. Okay. I got it. I got it. She's so beautiful. Oh my God.
It's a great moment, it's just not realistic. All right, so this is a happy scene overall, but 100% not realistic. I'm not even gonna comment anymore on this scene as this just would not happen. I understand the severe carbon monoxide poisoning, likely underlying fetal distress. You wanna prevent further damage. I understand where the writers were trying to go with this, but it's just not realistic. Overall, carbon monoxide during pregnancy is rare. Obviously it happens, and it's associated with high maternal and fetal mortality. Carbon monoxide crosses the placenta and leads to intrauterine hypoxia, and that can lead to neurologic complications later. So if you wanna make this more believable, make this a chief resident, make this a 4th-year EM resident on the back of an ambulance, 20 minutes out from the ER, the patient's about to go into arrest, and then, then it's pushing it, but it's believable. If you want to make this more believable, have the patient already in the ER. Definitely a few things that could have been done overall a little bit different to make this scene realistic, but it's just lacking.
Okay, kids, we got one open in the wire.
Mine's stable. You should go.
All right, let's move him.
All right, we got that.
Head him up.
Okay, guys.
Let's go. Everything move aside.
You think Dr. Rorsch ignores you because she doesn't trust you? It's just the opposite. She knows you're good. She's testing the rest of us. And I don't think I'm gonna pass that test.
What are you talking about? You know your stuff, dude. You just need confidence.
Does he though? Does he know his stuff?
You asked how I got in? Our dad is on the hospital board. My brother never told anyone. He thought people wouldn't take him seriously. Wouldn't matter anyway. He was born for this. I am not like him, though.
Then what are you doing here?
I hated psych. Hated it. I wanted something more exciting. I wanted what Mike had. So when my dad said he could get me in here, I jumped at it. Big mistake.
Did you know that they opened this place up in 1932? Light bulbs weren't bright enough back then, so they put in all these big windows so they could see what they would do. Imagine that. Hell of a night for you two. Started off saving a life, ended up almost killing someone.
2 people, actually. I missed an epidural hematoma.
I missed it too.
Know what that sounds like to me? A typical night in this joint.
Wow, is all I can say. If a typical night in that ER results in a missed diagnosis, I would not want to be in that ER. If your attendings are going to miss a life-threatening diagnosis every day, you don't want to be a part of the hospital. You don't want to be a part of that program. Literally, the resident stated he missed an epidural hematoma, and the attending literally states, that's a typical night. Huh? Like what? That typical to miss a life-threatening diagnosis? What other ones are they missing every day? Like, all I can say is wow to that. Please don't go to this residency program. Just horrible.
Hi, I'm Vanessa. I'm Ariel. I like your room. Thanks. You can put there if you want. Okay.
This seems probably honestly the best part of this particular episode.
Can you hear it? Yeah. I can hear it. I hear you, Daddy. I hear you.
All right, so at first I didn't quite understand what was happening here and then realized that the girl in the room was the recipient of her dad's heart, and now she's getting to hear her dad's heartbeat. So very emotional scene. I do love stuff like this. It can definitely tug on heartstrings. Honestly, this was probably the best scene so far. This scene and then the CPR for like literally just a few seconds earlier. I mean, honestly, these are the two best scenes. Everything else, not good. Stuff like this just gets you every single time.
Every ventilator ICU can spare. Got an apartment fire. We got 22 wins so far, burns, smoke inhalation, broken bones, and a heart attack. Yeah, we're gonna need a barrel of morphine.
The ER doesn't stop. Well, that concludes the live reaction for Code Black. I'm honestly glad this pilot is over. I critiqued and reacted analyzing the pilot for accuracy and realism. I had been putting this episode off for quite some time, and I wish I would have put it off entirely. I literally did this for you all watching. I had so many issues with this pilot. I feel like it had potential, but it needed better consulting physicians behind the scenes. The amount of medical knowledge lacking in this episode, the carelessness, the recklessness, the medical negligence was alarming. If you want to watch something for entertainment, sure, watch Code Black. It's great entertainment. I just hope you realize now what is real and what is not. If you want to watch something for accuracy and being realistic, Save yourself the time. Skip Code Black. Watch The Pit. This has been ER Medical Drama Critiques, and I'll see you next time.